Brilliant. So welcome. We can see the participants starting to join the session. It's weirdly, Zoom kind of works like actual doors, so people don't just all come in straight away, kind of comes in drips and drabs. So as many of the participants are joining, I'll just give a kind of quick intro and background to the whole session. Make sure you're kind of seated comfortably. We've got an hour and a half, which is kind of a fair amount of time, so make sure you've got your drinks and you've been to the toilet. I personally have wine. We've ascertained that Alain will be drinking water, but from a gin bottle. But whatever your drink or liquor is, tea or wine or whatever it may be, just make yourself very comfortable. I'm currently dialing in from London, but we always have very international audiences. So if you've been to any of the past webinars as well, it's always really nice when people post in the chat where they're dialing in from. We've got India and Edinburgh and the US and China. So it's a really kind of nice mix of a very, very international audience. So by all means, post in the chat where you are dialing in from. For those of you who have done your homework for this session, you will realize that we are currently one panelist down. So Marcel Tanner will be joining us very shortly, but in a kind of real action-filled panel. He's currently in a task force, so he'll be swooping in any minute now, by the time the whole session starts. And I'm sorry, I am in a very hot London, so if you hear lots of background noises of alarms and sirens, I'm afraid I'm not willing to close the window for all of you. So for those of you who haven't been to any of the seminars before, welcome. If you have, I'm really sorry, this will be the third time you've A, seen me, and B, heard this introduction. But welcome to these BRCCH webinar series on COVID-19 insights into research. So my name is Maxine McIntosh. I'm a research fellow at the Alan Turing Institute, which is the UK's Institute for AI and Data Science. And I'm also the co-founder of an organisation called One Health Tech. And very lucky for you, I am your host for the next hour and a half. So a bit of background, I hope that everyone who is here kind of knows who the Botner Research Centre for Child Health are. But if you don't, welcome. It kind of aims to bring together top scientists and clinical researchers from its partner institutions in a multidisciplinary and multi-institutional teams to iteratively identify needs, conduct innovative research, and scale and implement solutions for use in neonates, children, and adolescents worldwide. And the vision is really to create this kind of Basel Zurich hub of research excellence. I kind of whined in the past, I'm originally from Geneva, Montreux, and it would be good to kind of get those guys on the map too. Obviously, none of us here need to be reminded that we're in the middle of a global pandemic, but obviously the thing that has really brought to light for us is the real innovation that has come out of the pandemic, the way that different organizations are working together, different institutions have corralled and unleashed their resources and their goodwill. So it's been a kind of fantastic time for the world of innovation in health technology. So there have been these kind of three-part, this is the third webinar of a three-part series, and it's really to kind of highlight the amazing work happening across the BRCCH's collaborative efforts in Switzerland, and also to have, especially in this conversation, to have a dip into the world of the collaborative international COVID response. So we'd also particularly like to speak about technology here, public health, and certainly COVID in low and middle income countries. So today's panel, we're hearing from an ebullient lineup of international experts, and this session is going to cover everything from how you found your kind of current response to COVID-19, what we can think about in terms of learnings from other areas. There'll be a big focus about research translation and implementation, and also the role of emerging technology in the global response. And obviously at the core of a lot of what the BRCCH does, and most of these webinars, is actually also how collaboration and interdisciplinarity and partnerships really work. So I've now blathered on for quite a long time, and unfortunately that's still not the end. But before I do a wee bit of housekeeping about how the session is going to work, I want to introduce our almost complete panel. So first of all, we have Professor Alain Abric from Johns Hopkins, who will give us a wave. Next up, we've got Dr. Solly Makulisa from EPFL, who can also give us a wave. And last but not least, Ms. Akona Tangela from the Africa Centers for Disease Control and Prevention. So we will also hopefully have Marcel Tanner joining us shortly, but if not, to be honest, this is also already a really fantastic lineup. So how it's going to work is that we're going to go through the speakers who are going to give a wee bit of an introduction as to who they are and what they've been working on the last few months. We're going to hear a little bit about some of the projects that they particularly wanted to share with the audience, and then we're going to start a kind of interactive and discursive Q&A. And so again, I am a real stickler for rules with webinar etiquette, so I'm afraid you're going to have to deal with a little bit of housekeeping from me. So obviously, as always, we've had a really, really wonderful plethora of questions coming in from the Q&A, and I would like to reiterate, as usual, there is no such thing as a stupid question. We've got a real range of different audiences, different backgrounds. We've got professors and first-year undergraduate students, you know, all ranges dialing in, from clinical researchers to academics to hobbyists to entrepreneurs. So any question is a valid question. We've got a very nice audience. We've got a very nice audience and a very nice panel who will all be happy to answer whatever question gets fired at them. However, it's very clear where you have to put your questions. So you'll see that there's a chat function and that there's a Q&A function. So chat function that many of you are using now, which is really wonderful, is just to literally chat and say whatever you want. Please don't completely fill it with complete noise, but if you want to add any commentary or you want to introduce yourself, please use the chat function. If you want to ask a question, please pop it in the Q&A. And to make my life a lot easier, and also for it to be a bit clearer, if you've got a question for a specific panelist, if you can do a little @ and you can say their name, you don't have to write the whole thing, you can just write their initials or their first name. But if you've got a question for a specific panelist, do put @ their name and then your question. And if it's for everyone, you can just leave the question open. I'll do my best to go through them. Sometimes I'll bundle them, sometimes I will take them as is. If your question isn't very clear, I'll ask you on the webinar to kind of retype your message just in case I've misunderstood it. But please don't put your questions in the chat because they can quite easily get lost. And usually we're dealing with quite a high volume of questions. So it helps us if you can pop it in the Q&A function. In addition, if you're not completely sure you want to ask a question, but you want to get involved in the quality control of the questions that do get asked, you have an upvote function. So if someone's asked a really particularly good question, then just press on the little kind of thumbs up sign, which allows you to upvote. Also, last but not least, we are on Twitter, obviously. So the hashtag is BRCCH. So by all means, tweet at the speakers, the fact that you're here, what drink you're drinking, whatever it might be. It'd be great to see who's plugging it also on Twitter. And just a little reminder that the whole session will be recorded and it will be available after. Anna, you're such a good kind of co-host. You're like a hype man who comes in and just supports with extra stuff. You're so good at this. So yeah, Anna has kindly put the hashtag in the chat. So just a reminder that obviously the session will be recorded. So if you don't want your name to come up in the Q&A function, sometimes I read your name. If you wouldn't want your name to be said on a recording, by all means make your question anonymous. And luckily for Marcel, he's come in just as the really boring, lengthy intro to the whole session has wound up. But I hope you've had a moment to kind of refresh after your previous call.
Yes, thank you very much. I'm here now. Okay. Yes, hello everybody.
So I'll give you, don't worry, you've got a couple of minutes to kind of orientate yourself, Marcel, but we'll kick off with an introduction for the whole group. And then finally, I think that's my whole housekeeping done. And we can start with what you've actually come here to listen to, which is this amazing panel of international experts. So to kick off, I'd love to ask each panelist to give us a kind of wee bit of introduction as to who you are, where you're currently working, summarize really what the last 6 months for you has been, and one thing that you've been particularly proud of. And this can be a personal or professional thing. You know, lots of people have taken up new hobbies, finished memoirs, made loads of sourdough, so whatever it might be. I'd love to hear a wee bit of a background and introduction. So just going in order of who is on my screen, can we start with Solly?
Yes, thank you, Maxine, for the introduction, and a warm welcome to all our audience today. I'm a biomedical engineer by training and have been involved in entrepreneurship and startups for going for 20 years and over, having started in the US and continued in Switzerland and South Africa. I serve as the Deputy Director of the Essential Tech Center here at EPFL, which is the Swiss Federal Institute of Technology in Lausanne, for those of you the non-Swiss audience. Basically, the role of the center is to try and harness the cutting-edge expertise that comes from over 350 labs that we have here at the EPFL to try and promote disciplinary research initiatives that aim to try and support development impact. And recently, we've also been working on a new mandate to add humanitarian action and the promotion of peace. In the past, I've had the opportunity to also serve as in an advisory capacity to both to the Swiss government at some point and also to the South African government in the areas of science, technology, and innovation. And as far as my background is concerned, like I said, I originally actually I studied in the US, and where I obtained my bachelor's and master's degree in biomedical engineering at Brown University. And in between this period, I actually took a break and joined a startup company, which was my first exposure to entrepreneurship, after which I came back to Switzerland to complete my PhD. I come from South Africa. I mention this because I see there's a corner here from a small town in the Eastern Cape called Mthatha that no one normally would know, except that 2 houses away from where I grew up from, there was the Changela family home. So that is the link in this. This is quite an unusual situation. And with respect to what I've been doing for the last 6 months, really, it's been a very roller coaster ride. I love to summarize this by saying that to me, the last 6 months have been like a major suspense thriller from Hollywood, whose end is still yet unclear. But professionally, though, fortunately, by the time the lockdown and the whole pandemic took a grip in our region, we had managed at Essential Tech to really iron out some of the priorities that we wanted to pursue in that year. So we're able then to try to, even though we're on an individual basis, we're able then to try and implement some of the, the action plan that we had set up ourselves. So we still are in a position to try and actually accomplish some of the things that we set ourselves for. And last but not least, one of the things that I'm proud of since lockdown, in order to try and avoid all the boredom, I actually revisited. I'm very proud that I've had an opportunity to actually go running more often than I have in many, many years. And I even, because our kids were also locked down, so I even had a chance to go running with my kids, and I found out how good they've become since the last time I actually tried this endeavor with them. That's it from me for now.
Amazing. So have you kept up the running for this whole period? Because I think lots of people started out with good intentions, but it didn't last too long.
Indeed, yes.
I think we all need a bit of that self-motivation then. Amazing. Thank you for a perfect response to an introduction background for the audience to get to know who you are. I think given that really freaky and amazingly small world connection, I think we should go and go to Akona now, because that is such a wonderful small world story and anecdote.
Thanks, Francine. And it is such a small world. That's incredible. I didn't even know that. That's amazing. Considering that we lived in Mthatha. My parents lived in Mthatha for a couple of years as well, a couple of years back. In any case, so I am Akona Changela, and I work at the Africa CDC, the Centers for Disease Control and Prevention, under the African Union. And so essentially how it started was that the African member states felt a need to actually start something that was African owned to respond to all the public health events that were happening on the continent. Currently, due to the response, I lead or chair the Science Standards and Regulations Technical Working Group under the Joint Continental Response for COVID-19, and essentially lead the science innovations and research front of things due to COVID-19. In quiet times, I am a program manager for mortality surveillance and supporting member states in developing strategies on how to improve strengthen the mortality data collection. And so I'm a field epidemiologist by training, and I am from South Africa, as you now know, and I went to University of Cape Town. In fact, right now I'm in Cape Town. And so it has been a very hectic 6 months for some of us. I wish I could say it has been restful. I wish I could have used that opportunity to rest, but unfortunately not. And so as Africa CDC, because we are basically, our main role is to coordinate all member states, all 55 member states in the country, our key role has been trying to strengthen those joint collaborations across the country. But I did manage to start a garden, which is something that I'm extremely proud of. I actually have herbs all over. I have blueberry bush, which has started blossoming, which I'm very excited about, as well as some vegetables. So I think that's me for now.
I love that. Coordinating 55 member states. What I'm proud of is blueberries. Amazing. Thanks, Akona. Okay, so next up on my screen, we've got Alain. Go ahead.
Thanks so much. And I'll start by echoing the pride that those of us who are amateur gardeners feel in when we see a small tomato appear. So I feel that Akona's pride is very well placed. So I'm Alain Labrique. I'm a professor in the program for Global Disease Epidemiology and Control in the Department of International Health here at the Johns Hopkins Bloomberg School of Public Health. I currently serve as the Associate Chair for Research and the Director of the Global Digital Health Initiative here at the university. So our center is focused on the evaluation of ICT, information and communication technologies, as they're used to strengthen health systems, but also in testing new innovations in this emerging space of the global mobile revolution and how it can help us deal with health issues at the personal and population level, such as the pandemic we're dealing with right now. I trained initially as a molecular biologist and then an epidemiologist and a field trialist. So I've had the chance to study the cell and society at the same lifetime. So very fortunate. So I've been working in global digital health for about 2 decades now, and been supporting groups like BRCCH with their digital strategy, and worked with the World Health Organization, where I most recently served as the chair for the Digital Health Guidelines Development Group. But the last 6 months, Maxine and our distinguished colleagues who have joined us for this webinar, the last 6 months have really been non-traditional in terms of the work we've been called to do. I think they've drawn heavily on my training as an infectious disease epidemiologist. First and foremost, to be called up to the front lines to help with the deliberate infodemic that has accompanied the pandemic around the globe. So responding to the need from media to promote correct information about COVID-19, to educate community groups and groups around the globe about COVID-19, and really focusing on trying to ensure the place of science in a highly politicized pandemic, much more so than any previous public health disaster that we've encountered as a human race. My work in COVID-19 has combined a lot of domestic work. So looking at helping schools, organizations, and institutions function under this new reality. And we've been studying some of the direct and indirect impacts of COVID-19 on women and children in low resource settings like Bangladesh, where I've had the privilege of working now for over 2 decades. We've been looking here in the US at some of the social inequities that have been exposed by COVID-19 in the past several months. And we've just completed a national survey looking at disparities in resources, access to healthcare, knowledge, and risk perceptions, which shockingly have really varied along ethnic and socioeconomic lines. So I think in short, our days have been long, early mornings to early mornings, and not even late nights. They're completely unpredictable with 2 teenagers here in the home, one of whom is starting school in person, while our R0 is going up. I'm glad I have a very patient wife who keeps us all relatively sane. And the thing I'd say I'm the most proud of is 2 COVID-19 courses, which we launched with 2 weeks of preparation, which for those of you in academia know that launching a new course is no cakewalk. But we're now in our 2nd term of operations for this course with nearly 500 students from around the globe. So that's really been something that we've been very, very proud of, and a real team effort.
Amazing. That is a wonderful achievement. Obviously, it's nothing on Bluebees and running, but it's a wonderful achievement as well. Amazing. Thanks for that, Anna. So, Marcel, now you've had a time to kind of gather your breath and compose yourself, and catch up to where we are. Are you ready now for a wee bit of an introduction? So the exam question is a little bit of an introduction as to who you are, what the last 6 months have been like, and one thing you've been most proud of for the last 6 months.
Yes, of course. Thank you very much, Maxine. And of course, I've totally relaxed. It's now the last 6 months I start with this, have been always been from Zoom to Zoom, Zooming from Zoom to Zoom. And so this is not, I was just sometimes a little bit dense, or every half an hour an attraction. So it's a bit special. But starting first, I mean, as many of you know, my background is infection biology. And I started in the lab. And later on, I really moved in 1979 to the field. That's when I moved from infection biology to public epidemiology and public health. And I did this mainly with collaborations in Africa and Asia, particularly in one of my, let's say, I would say second home, that's Tanzania, East Africa, where I lived and lived in one row 6 years in Africa, and then came back, was in London, did a Master of Public Health to consolidate learning by doing. And so already during this period, I was exposed to epidemic and endemic events and disease control very much, hands-on, with some dirt on the boots. You see, it's not just making a nice epidemiological model, but maybe sometimes also just looking on how you look after cholera patients somewhere. It's at this stage when I then now, at the moment, I'm, after many years of being in the Swiss Tropical and Public Health Institute director, 2 decades, I'm now retired but not tired. And I'm now the president of the Swiss Academies of Sciences, all academies. And I'm also a member of the National COVID-19 Response Task Force, where I lead the expert group on public health. And so I have a lot of connections, of course, not so much only with scientists, but mainly also with the government, with politicians. And what is for me really very happy is that I'm not just looking at Switzerland, but I have all these old contacts from these many 4 decades of working in Africa and Asia. I'm connected with the governments and colleagues and former students in Africa and Asia. And so I have not official sometimes line, but I really have gained a wonderful overview of what is happening in the different parts of the world. And I see this again as a process of mutual learning for change. We learn together, not somebody helps the other one, but we just learn together and we make steps. And I think this is the thing which I'm also most proud of, that this process functions, and particularly in these task forces and so on. There are many forces, there are many tasks, and this actually means that you cannot theoretically just discuss about inter and transdisciplinarity. I'm very happy that we have achieved in these task forces that we truly have an interdisciplinary working way without going to congresses to define what is inter and what is transdisciplinary. We just do the job and we actually make the bridge between science and politics. That's I'm very proud of. And I'm proud of also that I'm still healthy and being in, as I said, retired but not tired. And I'm still accepted also. I'm in the risk group and I'm still accepted to participate in these things. So thank you very much. And I apologize again for having been a bit late, but I'm running around like hell today.
No, I think everyone is let off the hook for being late at the moment who works in this space. Thank you for such a wonderful background, Marcel. And I think that retired, not tired approach and little snippet is a wonderful quotation. So I hope everyone leaves and remembers that well. So I hope you've now kind of got to know some of our amazing panel, and some of the questions are kind of bubbling away in your various brains at home. So in order just to kind of have a bit of a deeper dive into some of the amazing work that each of our panelists are doing, we're just going to go around again and hear a little bit more in more detail on a specific project that our panelists wanted to talk about and share with you. And then hopefully that can incite lots of interesting questions. Again, these things can be really broad about clarifications on some of the things that our panelists have spoken about, or you can have bigger, broader questions about the nature of collaboration or the nature of translation. But I would definitely echo a thing that Marcel said, which is one thing that's been very beautiful on the back of the last 6 months is a reduction in the amount of bureaucracy. And so if anyone wants to ask a question about just getting stuff done, I would love to talk about that as well. So going back to the beginning, I'll maybe jumble it up a little bit. I'd love to invite Akona to kick us off with just a kind of deeper dive into a specific project you wanted to share with us to kind of get this section of the conversation going. Akona, kick off.
Thanks, Nancy. That's a really hard question for me because we are busy with quite a number of things. But one thing that really comes back to something that I have been working on for the past 3 years, which is mortality surveillance. So recently we've started supporting countries with ramping up their rapid mortality surveillance programs so that they can actually see excess mortality, whether it's indirectly or directly caused due to COVID-19. And so it's quite an exciting program because if you would understand, in Africa, there are some limitations in terms of testing capabilities and the likes. And so this should be able to help us to identify any indirect effects in terms of health service delivery that is currently happening on the continent. As well as whether the HIV programs like the HIV program, TB, how massively affected have they been through the COVID-19 pandemic. And it's really important for us to really understand what's going on the continent as well. As I pointed out, in terms of our testing capacity, even though we've done over 5 million tests now in Africa, that's still a bit low for a population of 1.3 billion. And so it helps in terms of supporting the already ongoing response that's happening on the continent. And it's pretty exciting working with member states and seeing the collaboration between the intergovernmental organizations who normally would not have to work together, bring in the statistics department, the ministries of health, as well as the other civil registration systems, to just come in together and see what data they actually have to use as baseline data and how they can start seeing the excess mortalities. And yeah, essentially that has been about it. We're still implementing it within the member states. So we are still just starting, and it's part of the Saving Lives, Saving Economies initiatives, looking at also opening and closing of schools and the likes within the continent. And I can go on forever, but then I think I will allow other panelists because I mean, we are working with a lot of different projects, such as sero surveys. We also have, in terms of technology, we have the Africa Communication and Information Platform that we are working on with the telecommunication agencies all over the continent to try and avoid misinformation. As Alain pointed out, in terms of infodemics, we're trying to go ahead of that curve and give the citizens the right information. And we're also working with, in terms of collaboration between member states, you've got the PENA BIOS system that we are just starting up, where citizens, governments will be able to see on an app what kind of restrictions are the neighboring countries having, and it also helps with traveling in terms of if you are tested in one country, which lab you were tested in, is it a validated lab? Members from the other country can also be able to see that and be able to say, well, you can enter into our country and the likes. Like I said, I could go on and on, but I think those are the 3 main programs that I think are quite exciting for me at this moment in time.
Amazing. And if I was to just quickly follow up on that. Hello? Sorry, I was getting your feedback. Is everyone on mute? Solly, can you put yourself on mute just in case?
What? Sorry? I don't have mute.
Oh, fine. Okay. No, that's right. I got a bit of reverb. My reverb is now gone. Sorry, Koenig, if I could just follow up really quickly and ask, of those 3 examples you gave, could you give the kind of one unifying thing that made them a bit of a challenge, and the kind of one unifying thing that you think why some of these programs have worked quite well?
So the biggest challenge is getting everyone to work together. It's true that the bureaucracy has gone down a bit, but then I think people's nature is still question having to work together and the likes. And so even in terms of data sharing in Africa, it's still a challenge to get the data that you need to be able to develop any of these programs and support the member states the right way that you want to. So I think the biggest challenge has been data. But we are definitely working with our countries to try and see how we can work that effort a slightly better. The other question that you asked in terms of, sorry, Maxine, can you—
the one unifying thing that has made them effective or successful? The positive side of that first question.
The positive thing is that South Africa has shown, I think, globally that we can work together and collaboratively. I mean, if you think about how quickly we all responded as a continent to the pandemic, I mean, mitigation measures were put in place almost immediately. And this is the political pull that we have at the African Union. Being able to be under the Africa CDC, we are able to pull in all the heads of states. And I think that is the biggest unifying thing, is making sure that at the highest level, you have the right commitment to make sure any programs within Africa can be put in. And so we have the whole Africa Joint Continental Strategy is led by the South African President, His Excellency Cyril Ramaphosa, as the African Union Chair. And so from there, then the ministers of health are also involved and under the steering committee. And we've also partnered and strengthened our partnerships with WHO, as well as all the other partners from around the globe. I mean, we work with Johns Hopkins, we work with London School. We've literally had so many more partners coming in and saying their willingness to help and how can they support the continent. And so I think that is one really important unifying factor. And the other, finding that the African diasporas are also very willing to help, because some of the technologies that have actually come in and come out have been coming from the diaspora community saying, well, we want to help and how can we help you?
Amazing. Thanks for that additional information. That's really wonderful to hear. I think next we'll go over to Alain. So yeah, hearing a specific program or project you want to do a deep dive on, and a little bit about what made it challenging and what made it successful or not successful. It doesn't have to be a success as well. But it'd be great to hear from you.
Absolutely, Maxine. I think just to build on Dr. Shangela's last comment, one of the vital roles that she and her team at Africa CDC have been playing in combating misinformation is something that really we cannot underestimate the value of globally. We find that misinformation spreads faster than COVID itself, and so we in the public health community have been really challenged to respond on the channels where people are spreading this type of information. WhatsApp and Facebook and Twitter have been just the tip of the iceberg for how quickly this disinformation can get spread through a community. And so, figuring out ways to inoculate populations, I think, is something that we as a research community need to do better at, figuring out how to prepare youth for not just this pandemic, but future pandemics, to be able to digest information with an ounce of wisdom as to where that information is coming from and whether it deserves a repeating, I think has been a real challenge. And I think, one unique part of this pandemic, and then I'll get to answering your question, has really been this issue of the deliberate misuse of, or deliberate use of disinformation as a political tool to destabilize populations has been something that has now been documented by researchers at Johns Hopkins and elsewhere, where trolls and bots have been amplifying this sort of incorrect messaging around COVID-19, around vaccines, that really has put us at a strong disadvantage when it comes to mounting an effective public health response. So the leadership of CDC here in the U.S. and regional CDCs has been really critical to participating in that conversation. I think, you know, in terms of the work that we've been doing, that really is one of the ones that I can highlight today is a project called Pandemic Pulse that we launched with the assistance of the J&J Foundation some months ago. And there's two exciting work streams. One is we've partnered with telecom companies, so large US-based telecom companies and a few groups that provide location-based services globally to, before the pandemic, largely to advertisers to send targeted marketing and to understand the movement of populations, which, as you can imagine, as using mobile phones as a proxy for social mobility, for distancing, for grouping, and travel, can really help us understand how people are responding to government interventions. You know, we can introduce interventions as public health agencies, but then we need to be able to measure the signal beyond just coronavirus cases, the signal of how well people are adhering to these NPIs or non-pharmaceutical interventions. And so groups like Cubic and Google Mobility have released data like this to researchers, and they can be very useful to add perspective to understand how well policies are working. And it's one thing that the data signals aren't as strong in the African continent, but depending on the region and which demographics and populations you work on, there are also ways of addressing this using those mobile phone signals. I put in the link, a link to the HIT COVID database, which is another project of cataloging these non-pharmacologic interventions, which is, we hope, a valuable resource to researchers looking at how do we respond to pandemic conditions, and looking at the speed and intensity with which these interventions were implemented might be very useful to understand how they've had an impact on the rate and pace of infections in a particular geography. And then I think lastly, the most exciting, actually cutting edge, it just crossed my desk this morning, part of this Pandemic Pulse project is a series of nationally representative mobile phone surveys that we've been doing to help understand beliefs, attitudes, risk-taking behaviors, protective behaviors, and disparities in health, as I mentioned earlier, by race and SES, experienced in the US pandemic particularly. And so because of the ubiquity of mobile telephony, we've been able to fill nationally representative surveys within 3 to 5 days of deployment. Really a shockingly fast way of capturing the pulse of a population. And so what this has already revealed just in our analytics in the past few days are some really stark disparities in economic resilience across racial divides in the US, people who are afraid of losing their jobs, of not being able to support their families as the pandemic progresses. The perception of risk that possibly reflects the different experience of the COVID pandemic by ethnic groups. So African Americans and Latinos, who are bearing the brunt of infections and hospitalizations and mortality in the US, also perceive different things at much higher risk than white respondents in this country. And so it really reflects the stark disparities in the way people are experiencing the pandemic from their perspectives and how they perceive this risk. And even sending children back to school is seen as safe or unsafe depending on the ethnicity of the respondent. And so that's something that is very concerning to us. But the last thing I'll mention from the survey that's actually I mean, you guys are the first to hear about this because the data literally came in at the end of last week, is the prevalence of stigma associated with COVID-19. So about a third of respondents report that they would feel ashamed if they or a family member was diagnosed with the infection. And about 50% of respondents report anxiety around being able to support their families during COVID. I think the most disturbing message for me right now is that about 35% of respondents overall reported unwillingness to get a vaccine if it were available, with a stark difference, 52% in African Americans, which reflects decades of mistrust and well-founded mistrust in a medical establishment that has not always been racially just and equitable.
Amazing. Thank you, Anna. All of you are really bad at following instructions. You keep selecting your favorite more than 2, 3, 4 programs you're working on. You're all very busy. But thank you. That was really, really interesting. And, same as Akona, really great breakdown of some of the very important work you've been working on for the last few months. So I can see some great questions coming in. I particularly appreciate Anne-Marie's question, which is not related to COVID, but I appreciate it anyway. But do keep posting your questions in the chat and upvote ones that you particularly want to talk about. There's definitely some key themes coming up around working with big tech companies and disinformation and inequities. So do consider some of those big themes that are emerging across the speakers. So next up, we'll just for a quick couple of minutes summarizing the 1 or 3 bits of work you particularly want to talk about and share with the group. Let's go with Marcel first.
Thank you very much. Yes, in 2 minutes, I mean, my point of these 6 months was really working in the National COVID Task Force, where we had many projects. It was not just to advise the government, but mainly also do our own studies, and in order to collect evidence and to bring together the evidence that would inform policy decisions that are being taken by the crisis team up to June, and later on just the Federal Office of Public Health. And the most fascinating thing is actually that interacted very well with also the work that I normally do, that is actually looking after the academies, where the dialogue between the politicians as well as the population is really in the center. And this work in the public health team, the projects that were very important, it's very nice that Alain mentioned the work they did on the whole social effects, and not only economic effects, but bringing really more insight into the social tissues following the lockdown, to do studies on stress, not so much only on mental health, but already stress. That is actually a very important issue. And I think these are the things which we could actually show, that basically the light lockdown, not for instance our neighbors in France, where they had a very hard lockdown, 1 hour, 1 kilometer around your house, that actually this had actually severe consequences on the social tissue and elements that Alain also saw in the different population groups, as we have also a very large heterogeneity in the population owing to asylum seekers, migrants in our area. So this was very not just interesting, but it was also very important that one could bring in this dimension of public health. And connected with this actually were then the projects where I'm involved, and also, that's what I didn't mention before, I'm a board member of the Bodnar Foundation, and also in the strategic advisory board of the BRCCH. So it was actually to deploy very quickly funds for meaningful projects. And so not having my own projects, but really being involved in stimulating, animating projects that were not just specific for Europe, of course not, but actually with the whole perspectives and strategy of the BRCCH, also for the low and middle income countries. And that actually this was a wonderful work. It's not just a reviewing project, but really to point at what is really a priority, what is actually balancing risk, how do you actually also ensure us, as Alan has said, as Akon has said, that how do you really get the data in order to, for the decision making, providing this tool. And this, the learning effect, what you learn there is tremendous. And this results in, for instance, in one very close relationship is with Western Kenya, where in Kenya, actually, you initially had the problem in Nairobi sitting, but now when the lockdown was opened, I mean, people went back to their home places. And so with Neema Kaseche, Dan Kaseche, we actually have a project on these peripheral health workers. Really, how do you make the preparedness in a rural area of Kenya where you have mainly imported cases coming in? And so this is really feeling home again in Africa to work on this project, but all being connected. And sometimes, and this is the interesting thing, you can tell to our federal council at the central level, you know, my friends, basically if you have very few resources, as you have in many countries in Africa, you can do much better than if you have a lot of resources as we have here. And so it is, again, what I said in the introduction, it's this process of mutual learning. It's not we help and the other one receives, but actually we learn a lot in this exchange. And I think this is, for me, the fascinating thing that gives me energy and enthusiasm.
Amazing. Thank you for that rousing finish. And then last but not least, just this last little section about hearing a little deeper dive from each of our panelists about something they particularly wanted to share. We have Solly, so round up this little section with what you wanted to particularly share with the audience.
Yes, thanks again, Maxine. We also, even prior to the whole pandemic, there's a few initiatives, research project concepts that we've been working on. And I will share one of those. You know, maybe just to give a background, it turns out to date, we have about almost 900 deaths that have occurred as a result of COVID worldwide. Whereas, in fact, if you look on the other scale, today, every year, you have almost the same number of deaths of children under the age of 5 dying from preventable causes of pulmonary diseases, notably pneumonia. And one of the things that have been pointed out by organizations and others, such as the WHO, World Health Organization, is the lack of access to oxygen. Oxygen is one of the, besides antibiotic medications and other things, access to medical oxygen is one of the reasons why these children actually die. So we've been working on a project on trying to understand why is this the case. And to cut a long story short, one of the things that breaks, that falls apart within this whole infrastructure is the logistic supplies that actually, because oxygen is typically delivered to the hospital via cylinders, which are then piped through to the hospital bedside. Or there are small devices called oxygen concentrators that actually take air and convert it and clean it up into medical grade oxygen. And these are the ones that are typically used in, especially in remote hospitals, because it's difficult to bring some of these cylinders there on time because of roads and all sorts of things when they run out. So a lot of these places have been trying to get these oxygen concentrators, but there's been a problem with the fact that they are breaking down. After 6 months, they all break down due to the conditions, because these devices were actually designed to be used in high-income countries, especially for cases such as home use, where you have a nicely controlled environment and everything is in good shape. Whereas when you subject them to extreme cases such as humidity, high temperatures, dust, things fall apart. So we've been trying to see how we can address this challenge, with a particular focus on, especially on trying to dent the problem of the high deaths arising from pneumonia due to the lack of access of oxygen. And in doing so, we've been looking at how we can not only provide the technology or try and improve the robustness and durability of the technology, but there's a whole ecosystem that is around, because you know, unless you are able to maintain them, they will not work properly. And unless you are able to as well train the staff properly, there's a whole host of things that are required. So we are trying to, which is one of the things we do at Essential Tech. When we develop a project, it's not only the technological innovation that we do, but we also try and accompany it with what we would call as an appropriate and suitable business model that will allow the deployment of this to happen in a way that is sustainable and reaches the impact that is desired. So in a nutshell, we have a project that we call a Global O2 Initiative that encompasses all these elements, trying to think in terms of how should we approach this? What is actually the total cost of ownership? Because people think, okay, I can afford to buy a concentrator today, but in the end, 6 months down the line, they cannot buy supplies, they cannot do, you know. And should we be thinking about the cost of access and how to optimize that? Do these places actually need to own this? Could we shift this burden elsewhere, and how can this be achieved? So that's the spirit of this entire Global O2 initiative that we actually were pushing through, and we were raising money, and we're lucky enough to be selected for funding by a major donor, which I cannot disclose currently, unfortunately. So that is one of the major things and it turns out that oxygen, with the onset of the COVID-19, oxygen is one of the preferred early interventions, in fact, even well before the implementation of ventilators as such. But so that really threw in even a different spin to in terms of the significance of the work that we're trying to do. So we're actually very excited about that. And last but not least, I would like to be also in solidarity with some of the speakers. I just want to outline another project that we've been working on.
You guys are terrible at being disciplined in your, you do too much. You do too much. You got to be quick, Solly, but go ahead.
No, but I bring this up because of the comments that have come from both Alain and Marcel. We've been actually looking at the problem of how we can supplement and strengthen, the whole mental health, in developing countries, with a particular focus on sub-Saharan Africa, where the key indications there that are problematic is depression and, PTSD, post-traumatic stress disorders, substance use disorders, especially alcohol and tobacco, and now we even have other things that are coming up. So this is another, and it turns out that this, in fact, the landscape of mental health has even changed that much more. And some of the speakers before are highlighting it, coming in from different angles. So this is another initiative that we have actually been, where we have put together an international consortium from Swiss partners in Tanzania, South Africa, the US, etc. So that one, we are still in the process of currently fundraising. That's the challenge that we are facing now. We are all talking about the challenges of trying to contend with the problems posed by mental health, but there are not enough resources that are being allocated to actually support the realization of solutions. So that's the main challenge that we are actually facing for now, but we're soldiering ahead. That's
amazing. Thank you for all your summaries of all the amazing work you've been working on. So thank you for your questions that have been coming in. Thank you for those who've been upvoting the ones you particularly like, and Alain has been diligently responding to the ones that were personally thrown to him. So by all means, keep dumping your questions in there. I think I might, as per usual, do a bit of a hash and try and combine a few of the great questions coming in based on some of the kind of key themes that have emerged across the speakers. And I want to kind of start with the first one. So it's, I'm not sure if it's Higenyi James or James Higenyi, but I think I think he's from Uganda. If I could, he's been in quite a few of the last webinars, and he often asks good questions. But his question is, what sort of ethical and practical framework do you operate under? So obviously this is like a very broad question. I know that a number of you are very involved in regulation and standards. And obviously this has been, and this has come up in previous webinars, but this has been a time of kind of practical and realistic innovation, which means that sometimes some corners have to be cut. So those corners sometimes might have to be ethical, sometimes they have to be standards, they sometimes have to adhere to regulations. So I'd love to hear from a couple of the speakers, and maybe we'll start with you, Solly, because you talked about kind of practical and sustainable innovation, and really thinking about business models. So personally, what sort of ethical and practical framework do you tend to operate under? What's the kind of, how do you approach it? So obviously you've talked about a sustainable business model, but it'd be great to go into a bit more detail in terms of how you've been approaching this during the pandemic, and how that might have changed in previous times where you didn't have the pressure of very, very fast, but also very, very frugal innovation. And I think probably be great to bring in Akona and anyone else who wants to talk about how the ethical and standards framework and regulation landscape, I guess, has changed in the last 6 months. So Solly, do you want to kind of kick us off with how you approach ethical innovation?
Yes. There are two aspects to what I mentioned, and one is development of the technology. And typically the technologies that we develop, there is anyway a certain regulatory pathway that is well defined. And what we always say at Essential Tech is, for us, whether or not the technology is designed or intended to be primarily operated in the rural district areas of Africa, we are still going to respect all the norms, standards, and regulations that apply in countries where we live in. So we just are not in the practice of trying to cut corners. I think if it's a medical device, it must go through the standard rigor of any type of medical device. We must be able to put this device to be functional here where we live in Switzerland. So that is maybe a short answer to that question. Having said that, of course, some of the major regulatory organizations, such as the FDA and etc., have put in certain measures that allow the acceleration of the approval, of regulatory approval of such devices. And in a case where we would have had a device that actually fits in there, we would have taken note of that. But to cut a long story short, we still stick to the standard like CE marking in the case of Europe, etc. Now, coming to the second one, in terms of the business model, very early on, one of the approaches that we do here at Essential Tech, before we actually launch the project, we go in and identify the key stakeholders. We try and identify pilot countries where we are going to launch the innovations that we are trying to develop. And in there, we find the suitable stakeholders who we talk with them and try and understand the problem and hear what type of solutions might potentially be of interest and acceptable. And if we come back to the project of Global O2, for example, we are working with, we identified one of the guys that we identified to be really the key stakeholder in the area of oxygen is in Kenya. We're actually working in Kenya, is a CPHD, Center for Public Health and Development. And they were actually very, very, they are probably the leading entity that has tried to solve the problem of generating and providing oxygen to the different areas. So we work with them to try and develop a concept. And part of the project that we're going to do is they have now received, for example, approval from the government there, where we can have access to specific hospitals where we can test this business model and respect the local, clearances or ethical approvals that are in place there. So this is not something that we try and effect from here in Switzerland. We also rely on our local partners who we co-create whatever we do, which is the spirit of what we do. And having said that, though, I must remind you, though, that institutions like ours have very, very strict guidelines. As soon as you have a study that may involve in any form of interaction, there is a very rigorous, ethical, clearance process. So there is just no way that we, and we are happy with that. It's sometimes very painful in terms of paperwork, etc. But I think it's all for the good.
Absolutely. So, and I think everyone wants to say something in response, but I might bring you in, Akona, as one of a kind of queen of standards and regulations in the committee. So obviously we've very different regulatory context across the African continent.
Yeah.
And obviously COVID provides a really good opportunity to innovate, but also stress and strain the current existing regulations and standards. So before I bring in Alain and Marcel, how have you found the last few months in terms of specifically looking at the changing regulatory and standards environment in Africa?
So yeah, Maxine, it's a very complex question to answer because we still respect the regulatory bodies within the countries, and the best way we have found to fast track or to help with the process is to work with partners such as the African Vaccine Regulatory Forum, which has strong leadership in terms of regulating the regulatory boards and the ethics committees. Ethics committees and regulatory boards in Africa can actually be one thing. And so the question is then, how do we bring together all of these bodies to work together and to also understand the pandemic and the need to rapidly respond to it in terms of research? One of the challenges is that some regulatory boards, for example, will not allow vaccines within the country to be conducted. And so working with institutions such as WHO, such as the African Vaccine Regulatory Forum, as well as the African Medicines Agencies, which is under NEPAD, this helps us in terms of fast tracking and also directly speaking with the regulatory boards in order to process everything. But it's still a challenge because member states have solidarity, and we wouldn't want the processes to change just because there is COVID-19. I think even for every research that we have done as Africa CDC, we have gone through the regulatory process within the countries, such as the PERC study, which I just put up on the chat. That went into the various regulatory boards within the countries, writing them a letter from the African Union requesting for us to conduct that kind of research. So ethically, we want to be trusted. And so even with the vaccines, we wouldn't want to introduce a vaccine that hasn't gone through the correct processes within within the continent. And so the question is, how do we standardize and ensure that there's harmonization amongst the regulatory bodies in order to implement these? Yeah, so it's a difficult question to answer because it's also still a challenge for us as well.
Yeah, absolutely. And it's certainly in the UK, we had a thing called the COPI Directive, which overnight effectively forced providers to share data for their response to the pandemic. And it kind of culturally changed everyone from giving you 150 reasons why you couldn't share data. We have to share data. So it's interesting how also kind of the culture and regulation intersect in terms of how willing people are to, cut corners. I appreciate is a clumsy way to do it, but use the regulation in the spirit in which it was designed. So Marcel, I know you've had your hand up for quite a wee while, so can I bring you in to either comment on what Solly or Akona said or to say your own thing? Go ahead.
Thank you very much. It's not so much only a comment, but also a little bit the experience of all these years. And I think people tend to forget, it's also your remark, what has happened now in the UK. I mean, we have had Ebola, where we had similar problems. We have had actually the situation when we were starting in 1992 with the malaria vaccine trials. We had similar things. We had urgency, we had people dying, but we had also to follow the pathways. And every time is clear, we don't make a compromise on science and on ethics. This is not the issue. I think the issue is to rethink designs that allow you to have rolling procedures in order to really do trials, be it a drug, be it a vaccine, and so on, that are speed up through the way how you design, but not to making compromises on ethics and so on. And I think this is what is not very well understood in the population sometimes, and people tend to forget all the steps we have made. For instance, Ebola was not the issue of the regulatory bodies. I mean, the ethical clearances, the registration and for use, this came in with 1 week or something like that, or in 10 days. This is not the issue. The issue was that one had actually the designs in order to bring in a new technology, a new tool in a more effective way. And I think this is, we should not forget. I think this is the way forward, you see. And that's what I wanted to see. I mean, I would like to say, with all my bias, I've been over 10 years chair of DNDi, drugs for neglected diseases. This was the main issue, to bring in new treatments that were actually not the new chemical entity, but sometimes new combination therapies and so on. We never made a compromise in terms of ethics. We always actually looked at the design. How can you also, with a comparative approach, multi-site approach, gain a lot of information about safety, about immunogenicity when it was a vaccine, and also in a way to move forward. I think this should remain the principles. We have worked hard to get these standards established, and it would be a really wrong way forward if we would start lowering these standards, that they are absolutely needed.
Excellent point. And Anna, I saw you put your hand up. Has the moment moved on, or you would still like to comment to it?
I think, you know, there's been a lot of good points made, and I think we all stand in solidarity that compromising ethics is not something that any scientist in their right mind considers even during the worst of pandemics. Helsinki principles, Belmont Accord, all of these apply even in the worst of times. And I think, you know, we have seen just this last week, the public statement from the top 6 or 7 vaccine manufacturers committing to not cutting corners in the development of vaccines and making sure that patient safety is paramount, illustrates this commitment. Now, not every company in the globe working on a COVID vaccine has signed that statement, but clearly the forerunners are on board when it comes to protecting privacy. I pasted a few links in the chat around new laws and regulatory provisions that some countries have issued in order to be able to use technologies. So I know the FDA and US government has issued a number of emergency use authorizations, which I would say get rid of a lot of the bureaucratic obstacles that prevented rapid deployment of solutions. And I think the best case in point is telemedicine, right? They opened much wider the door for telemedicine solutions that were maybe not gold standard, but that allowed patients to see physicians without taking the risk of going into a clinic or hospital, potentially exposing themselves to COVID. Allowing the use of chat messaging apps as a way of communicating with patients that may not have been HIPAA compliant, you know, the highest standards, but when you balance the risk of potentially exposing a vulnerable patient to coronavirus versus being able to have a quick face-to-face consultation, the Health and Human Services felt that a temporary suspension of these very high barriers to using technology was justified. And so I think it's a risk-benefit calculus that is has a very high bar of protection of human subjects and patients at all times.
Yeah. So I might kind of be cheeky and play devil's advocate and push back about the collective assumption that we're all adhering to a high ethical standard, because many of you mentioned the involvement of telco companies, and in many respects, these companies are not your traditional healthcare players, right? That some in some respects were involved in previous pandemics and epidemics, but I don't think across the globe, we've seen these companies involved at the scale at which they've been involved before. So this can be from a tracking perspective or from a disinformation perspective. And they, don't tend to adhere to the same standards of ethics or clinical regulation as obviously current pharmaceutical companies, for example, or medical device companies adhere to. So I'd love to hear from the panel about your experiences in dealing with these sorts of companies, but also what you think the future holds now that we've got effectively big tech players who are now major players in health responses. So Marcel's first one here with the hand up, and so it gives it the rest of the panel who have had some time. So Marcel, Alain, and we'll kick off. So go ahead, Marcel.
Thank you very much. I think this is a very important question, and it's true that these companies are not functioning in the same mode. And I think I would not just put it at tech companies, IT companies. The important issue actually on this is the artificial intelligence part. And I think that is actually, I think this is the area where, for instance, we are now really going towards a global index like corruption index and so on, that you actually really look at how the artificial intelligence is used and needed, and that there are certain standards needed, because that's indeed, as you say, Maxine, this is a very important area. So the point is not only just to ask them to adhere to those standards in R&D that we have well established, right, but that we actually have to have for particularly the use of those data in artificial intelligence, and that we don't have a lot of acrobatics of some, as companies have done already, not only in campaigns, but I think this is really a point that we should bring forward. And here I can say without hesitation that the Botnar Foundation, being very much involved in the artificial intelligence field, has put this as a first ranking thing to cover this difficult area.
Yeah, absolutely. And as someone who spends a lot of her time trying to develop very poorly performing artificial intelligence models, I have to say this has been a period where just simple stratification and incidence and prevalence plots seem to be far more impactful than your latest artificial neural network, which is both a useful and slightly depressing thought. So Alain, do you want to comment about?
I think briefly the telecom companies may not be governed by the same ethical regulatory standards that researchers are. However, when they collaborate with public health authorities, they do fall under that umbrella by extension. But I think a more powerful tool sometimes is the risk aversion that comes in the private sector of endangering the reputation and the public perception of telecom companies' sort of track record. And so to some extent, that also is a strong disincentive to engage in any sort of shady activity that you might expect from those specific groups. But I think the real lesson that we've learned is in countries where, especially countries in East Asia, where the previous SARS outbreak and other respiratory epidemics have maybe prepared them somewhat more profoundly than the rest of the world, has seen legal and ethical standards being put in place. For example, in Hong Kong, there are extremely strong data protection standards that were developed as a response to the first SARS epidemic to allow public health authorities to access phone records, location records, for the purposes exclusively of public health protection. Now, these came with very strong consequences if data was misused or violated for other governmental purposes. Now, again, we can go into a whole side conversation around trust in government and abuse of citizen data, but legal institutions being put into place is a very strong precursor to enable the use of these technologies during a crisis. And so if you look at Australia and New Zealand, they've also enacted very specific legislature, even naming the applications being used and the sort of risks and consequences to those companies and to those stakeholders if the data was misused. And so, for example, in the US, we do not have a central data protection agency like there exists in many European countries to ensure citizen data protection. So I think there are there are more protections in place than we might think. And it's contingent on researchers and the research community and the public health community to make sure that we are calling out failures of those protections when they are taking place.
Fantastic. So Marcel, I see you have your hand up, and I want to also dovetail to Akona to respond to Alain's point about.
It's an old hand. It's an old hand.
It's an old hand. You should lower your old hand and make sure it remains new.
I don't know where the hands are, so.
if you
it's fine. I can wave it. Keep going.
Yeah, we can wave. I'm flexible. Your real hand, your digital hand, but you don't need to like hang out there limply for a long time. I can see it in a flash. But Alain made a really good point, and it's a point that has also come up in the Q&A, which is preparedness based on previous experiences, obviously a point that Marcel also made. So when you're reflecting from an international perspective about how you feel the African continent has been responding to COVID, obviously Ebola is in the kind of quite recent history, and many other continents almost didn't have that experience. So how do you feel that the African response has compared to other places that maybe haven't had any sort of pandemic or epidemic recently?
Yeah. So that's true. I mean, I think Africa was probably better prepared for putting in the measures, especially at the airports. And when you talk about Ebola outbreak, we're not just talking about the West African outbreak. DRC still has an ongoing Ebola outbreak as we are speaking. And so its neighboring countries already were under preparedness measures for Ebola across the continent. We as well had been training member states in terms of epidemic response during the time of the Ebola outbreak in DRC. And so we hope that those kinds of measures and that kind of preparedness, and also having the experience to respond to various outbreaks within Africa. I travel a lot around Africa, and we respond to a lot of outbreaks, cholera, malaria, etc., you name it. And people know contact tracing, and they understand why health workers are at their door trying to understand what is happening within the community. And so contact tracing is not a new thing for Africa, because they've had experience in actually going into the communities and trying to identify the cases for any disease that is currently causing pandemics. And so I think we were kind of better placed, and as the figures seem to point in that direction, Africa has been less affected than the rest of the globe. And so even though we're still trying to understand why, but I would hope that our early response to the outbreak, putting in place the mitigation measures, when some countries went into lockdown when they only had one case. And so we hope that those were very effective in trying to definitely slow the pandemic within the continent.
Yeah, wonderful. So there's a question that's coming from Marianne Sharaf, which it talks about disinformation in South America, and this is something that Anna mentioned as well. A couple of you have mentioned the unhelpfulness of disinformation and how quickly it spreads. And one thing I wanted to ask, and maybe we'll kick off with Anna, is that in the HIT COVID paper was very interesting because as you mentioned at the beginning of the session, it compares the database compares the effectiveness of different non-pharmacological interventions. And so on the disinformation point, how big an effect do you think disinformation has been? Which I appreciate is harder to measure necessarily than a positive intervention. But how big is this in terms of a problem? Because you see it floating around all the time. But is that the kind of real pandemic we should be addressing now?
It's a great question, and it's something we're trying to measure through the use of these surveys. I think when we include questions around willingness to take a vaccine, when we look at the use of drugs as prophylaxis, we asked a question around whether any of the respondents was currently taking a drug that they believed would prevent them from getting COVID-19. The answer was well above zero. And so this may cause, as our colleagues here have mentioned, there's a risk of real harm to people taking drugs that they believe that will either prevent them or even cure them should they get infected without adequate clinical information. And so I think that's a very direct impact of the misinformation or disinformation epidemic that we're seeing. But I think the most salient example of this, I think, is the global mask debate that has emerged around the pro-maskers and the anti-maskers, and this conflation between public health measures and restrictions that suggest infringement on individual liberties. And so it's sort of a greater reflection of this global social media driven individualistic culture that has been now promoted thanks to a lot of this social media presence that we all have, but it's made public health interventions very difficult to implement at high levels of adherence because of conflicting information that in some cases has been deliberately planted to create chaos. And you wonder, just to say, back in 1918, during the influenza global pandemic, there was also anti-mask
did not have
lobbies.
TikTok. You can't blame this on TikTok.
It's not TikTok, but there were anti-mask lobbies and anti-mask demonstrations as well. But they were sort of the lunatic fringe. And so, making these side beliefs mainstream has been one of the big challenges of this pandemic for sure. And the data points to it very clearly. Yeah.
So before we wrap up with our final question, which I'm going to take from Anne-Marie. So I'm going to ask you a question that's coming for you, but then I'll also give you all a bit of time to prepare this very, very good question from Anne-Marie, which is at the top of the chat, which effectively says that, we've got loads of these different initiatives and everyone's kind of coming together and firefighting and working on new different types of programs and projects. And she asks very pointedly, I don't want your whole bucket list. I just want one key piece that should be the response to solve it, to effectively kind of responding to the crisis. So she gives examples. For example, a global fund for pandemics, or more localized community-based funds for interdisciplinary preparedness. So have a think, whilst Solly's on the spot, busy answering the next question, what your kind of one key bit one key solution, I guess, or the one key thing that needs to change in order to improve the COVID response would be. So whilst everyone's busy racking their brains about how they're going to answer that, Solly, there's a question for you specifically about essential tech, which is, are there other sectors outside of healthcare that oxygen could be sourced from, or technologies that could be repurposed for medical use? So I think that there's obviously a specific question there, but I think there's a broader question, which is, what can we steal and copy and use from other sectors that could be applied in healthcare?
Well, it turns out that, in fact, medical oxygen accounts for about 5% of all the oxygen that is actually produced out there. So oxygen is used in all sorts of industrial applications elsewhere. Again, there's always the standards and accountability and other things that apply when you don't have a medical device or medical intervention in place are different. So one is tempted to say, in principle, yes, but there has to be a transformation process that allows that to be used in that circumstance. But again, like we said, one of the easier ways that have been identified is just basically either cylinders, which are not working because of infrastructure and other things, and the concentrators do work well, but they will, they don't function in that context. And the other machinery that's used might also have a higher level of complexity that will still need to be tailored to fit the application that will be required for those district hospitals. So it's not a straightforward answer, so to speak.
Yeah, no, but thank you for answering that. So because you are all a misbehaved panel, which I also really appreciate. I'm going to give you 1 minute to answer Anne-Marie's question. So just to remind you, it's that there's lots of great examples out there, but in order to improve our capacity to respond, what's the one thing that you would recommend? So if you go over a minute, then I'm afraid I'm just going to cut you off because we've only got 6 minutes left. Okay. Solly, you can go last because you were busy answering the last question. So let's start with Marcel. 3, 2, 1, no pressure.
Thank you very much. I'm very happy that we could come to a conclusion that actually points to an outlook. And I think the main issue is not to create a global fund, but the main issue is really that we all take in the position where we are, the roles and responsibilities in a serious way, because these are not often defined. We are all part of something, but we are actually not taking these roles and responsibilities very seriously. And we always look too much actually at our responsibility where we say it's the own responsibility, we can think, and it is much more the community responsibility that counts and must count, because instead of creating new instruments. I think this is how we move, and a more rigorous pursuit of this work. And then with this mutual learning, we'll achieve. Thank you.
Ooh, on the dot. There we go. So I have to say that I'm now, I'll tell everyone who's currently watching, I'm getting very anxious private messages from the panelists saying this is such extreme pressure, but this is good. If you can handle a pandemic, you can handle giving a summary in 1 minute. So Akona, go ahead.
Maybe just 5 seconds, universal healthcare coverage. Equitable healthcare is what we need. I mean, the stats don't lie. The most affected population are the poorest population. And there's a reason behind that, is because they do not have the right healthcare support as those who are better and affluent, I mean. And so for me, that will be the outlook. Whether we are using technology or not, in Africa, it may be slightly, take us a bit more time to put in AIs, because I mean, 23% of the population actually has smartphones. So if we can work through improving our primary healthcare systems and ensuring that everyone has equitable healthcare systems, then I think that will help us in fighting the epidemic.
Amazing. Oh, 10 seconds to go. I feel like I could be generous and donate your 10 seconds to someone else. Alain definitely wants your extra 10 seconds. Fine, I'll negotiate. Alain, you can have an extra 10 seconds then. Okay, so Alain, 3, 2, 1, go.
Yeah, I don't even need the 10 seconds. Building on Akona's last point, I think we can't implement measures to control pandemics without making sure that individuals are supported in their capacity to adhere to those measures. So if you're going to ask people to shelter in place, to quarantine, you have to make sure that they're able to receive food, medical supplies, continuation of healthcare. It's not just about universal health coverage, it's about universal societal responsibility to those who are least able to take care of themselves and their families. So I think we have a greater responsibility than just taking care of the health. We need to take care of the social conditions under which health programs are either successful or fail.
Yeah, absolutely. And one thing that we didn't manage to chat about, I appreciate I'm breaking my own rule here. One thing we didn't get to chat about that I would have loved to discuss was a point that Akona and Solly both made about when they made the case of TB, but mental health, the kind of secondary and tertiary effects of COVID are going to be a kind of really interesting source of collaboration and innovation. So Solly, you're the lucky one. You get the last word. There's no pressure. It's got to be really good. We're all waiting for it. And we're all very excited for it. So you're on mute. You're so nervous. You've got to take yourself off mute. So go ahead.
I've got all that pressure to put that game-winning shot with the time running down. So anyway, in my opinion, there's no single magic bullet to this. But having said that, one of the things that I personally, am a big advocate for is the intensification of efforts to implement that can help to implement effective, what I would call effective track transfer, upskilling and other resources that would enable a local manufacturing of key essential products. So in a nutshell is what can we do, what resources can we master to really make local manufacturing of certain things that we need a feasibility. and stop trying to rely on what we see, on the logistics that are centralized in certain parts of Asia, as we saw the challenges with that. That's my story.
Perfect. You're actually all very well behaved when you're given appropriate constraints, it turns out. Thank you for a wonderful close to the panel, and also a huge thank you to Anne-Marie for a really great question that was a perfect end to this panel. So thank you for joining us. Thank you for joining us. If you've come to all three, if you've just come to this one, then you did miss out. But if you want to catch up, then absolutely you can look at the previous recordings that are on YouTube. The recording for this event will go up in a few days, depending on how hard the BRCCH team work. But a huge thank you to all the previous panelists in the previous webinars, and obviously to this current amazing panel, and also to the BRCCH team for doing a really fantastic job in organizing this webinar series. For many of us, whilst Zoom has become a slightly painful everyday activity, it is a slightly different type of activity running and coordinating events. So a huge thank you to a fantastic team at BRCCH. So remember, you can carry on the conversation on Twitter. I'm sure the panelists wouldn't mind being reached out to as well. So by all means, follow up with any things that were said or missed. Obviously, most of the chats we did miss because there were too many things to talk about. But I hope you now go back to your dinners or your families or your breakfast, depending on where you're dialing in from, with a rich mind and a whirring brain. So have a wonderful rest of your day wherever you are, and a huge thank you again to Anna, Solly, Akona, and Marcel. Thank you. Bye-bye.
Bye-bye. Bye-bye. Thank you very much. Bye-bye.
Thank you, Maxine.
Bye-bye. Thank you, Maxine.
Thanks, Maxine. Good to see you.